Good day. This is the second lecture of session 3 from the clinical pharmacology module. My name is Dr. Majid Hamid. In this module, we have six learning objectives that should be covered. To start with the scale of the problem of Atheromatous disease. Sometimes we call Atheromatous disease as atherosclerotic cardiovascular disease. They have the same name, which means uh, the presence of atheroma in the wall of the blood vessel. In fact, atheromatous disease is the commonest cause of death and disability worldwide. Why? Because atherosclerotic cardiovascular disease, such as myocardial infarction or ischemic heart disease, acute cardiac arrest, or cerebrovascular accident or stroke, these are the atherosclerotic cardiovascular disease or the atheromatous disease, and they are the commonest cause of death and disability worldwide. And it is a chronic inflammatory disorder which can manifest as early as adolescence. So it does not affect elderly people. It might affect even adolescents and young people. And in a few slides, I will explain why it is a chronic inflammatory disorder. And the majority of affected patients are between the age of 50 and 60. And once you get to the age of 50, it is very highly likely that you will have a varying degrees of atherosclerosis. So the older the age you got, the more likely that you will have atherosclerotic cardiovascular disease or atheromatous disease. And the major treatment for these disorders is a statin. And the statin were discovered in 1976. And these are uh, represent the most powerful treatment for atheromatous disease. And LDL is considered as the major risk factor in myocardial infarction and stroke. In this diagram, you can see very clearly the association between LDL cholesterol and the relative risk of coronary heart disease. So, as you can see in this line, in the x-axis you have the LDL cholesterol level, and the y-axis you have the coronary heart disease risk. The higher the LDL level, the more likely you have coronary heart disease. And in this survey that was conducted in the Middle East and North Africa region, that is the region where we live in, they did a survey on the population and they found an interesting result. You can see here 70% of adults they have dyslipidemia, and it is more common than even abdominal obesity or hypertension or obesity, diabetes or smoking. So around two-thirds of the adult population they have atheromatous disease. So it is very common disorder and you will face it a lot during your clinical life. And we have many lipoproteins or lipids, but the major two important lipids include first LDL or low density lipoprotein, and this is the bad lipid. This is the one that accumulates in the blood vessel and causes occlusion and atheroma. While the good lipid is called HDL or high density lipoprotein. Also, it is called the scavenger. It cleans the plasma from the bad lipid, the LDL. So if we have a good treatment, then that treatment should lower LDL and increase HDL. And the lower the LDL reduction, the more cardiovascular benefit we got. And there are reference ranges for the different types of lipids in our blood. For example, for total cholesterol, the normal value is equal or below 5 millimole per liter, which is equal to around 200 milligram per deciliter. while for the low density lipoprotein, the bad lipids, LDL, it should be less than or equal to 3 millimole per liter, which is equal to 120 milligram per deciliter. While the good lipid is the HDL, it should be equal or more than 1.2 millimole per liter, or equal or more than 48 milligram per deciliter. And these are arbitrary and not unique for the whole population. Simply to transfer, convert, sorry, millimole per liter to milligram per deciliter, you just multiply by 40. Each 1 millimole per liter is equal to 40 milligram per deciliter. And the mechanism of Atheromatous disease or atherosclerosis is very simple. Imagine this is the blood vessel. This is the endothelial layer. Here is the blood or the plasma. And here we have the intima, and then the muscular layer, and then the adventitia. Whenever there is endothelial wall defect or dysfunction, the LDL particles in the blood will get into inside the blood vessel wall, specifically in the intima. And once they are enter the intima, they will induce oxidative reaction and inflammatory action. That's why we call it a chronic inflammatory disorder. This oxidation will stimulate the proliferation of many cells, inflammatory cells, such as monocytes, macrophages, and T lymphocytes. They will accumulate here along with the smooth muscles, and this will form the atheroma. And this figures simplifies the thing further. So these are the LDL lipid particles. They enter through the endothelium of the blood vessel, and then the other inflammatory cell will enter, a lot of lymphocytes, a lot of macrophages and muscle cells. It will end up with the formation of what is called atheroma. And the atheroma consists of a core of lipid rich and covered by a fibrous cap. And whenever there is a break in the fibrous cap, this atheroma will represent a nidus for thrombosis, or it will stimulate thrombosis. There will be total occlusion of the blood vessel. So here is very clear. This is the blood vessel already is narrowed by the formation of the atheroma, which is consisting of a lipid-rich core in the center, covered by a fibrous cap. And whenever there is rupture of this plaque or atheroma, there will be thrombosis and total occlusion of the blood vessel. And this is the principle of myocardial infarction and cerebrovascular accident. Again, this is a patent blood vessel. It is fully open. This is the normal blood vessel. But then the atheroma will form due to LDL particle. And this is the atheroma, as you can see here. And once there is rupture in the cap of the atheroma, there will be total occlusion of the blood vessel. This is a real coronary artery. The coronary artery, you know, supplies the heart with the blood. So this is the left main artery, main stem, and this is the left anterior descending artery of the heart. And as you can see here, there is a big thrombus occluding the blood vessel. So we are expecting this patient died because of acute myocardial infarction. And again here you can see the blood vessel is totally occluded by the thrombus. Can we prevent atherosclerosis? The answer yes. The prevention of atherosclerosis depends on three main factors. First of all is the diet. It should be low in fat, especially the bad fat, like the animal fat. The second part of prevention depends on the exercise. exercising every day and regularly, keeping a good physical activity will reduce atherosclerosis. And finally is the drug, and we have many drugs that we're gonna talk about them in a few minutes. So all of these pillars or factors at the end, all together, will increase HDL, the good lipid, and reduce LDL, the bad lipid. Now we will talk about the lipid lowering drugs, and we have seven major families or groups of lipid lowering drugs. The most common one and the oldest one is the statins, and we will talk about the statins in more details shortly. Then we have the cholesterol absorption inhibitors, such as ezetimibe. We have the fibrates, such as the fenofibrate. We have the omega-3 fatty acid, the fish oil, and we have the bile acid sequestrants like cholestyramine, and we have the niacin, the nicotine amide. And finally, the most recent of all is the PCSK9 inhibitors, the pro-protein convertase subtilisin kexin 9 inhibitor. It's a very powerful agent that was discovered recently, like the Repatha, the evolocumab. Let's start talking with the most common drugs, the statins. These are the most common, effective, and best tolerated drug for lowering LDL, and they are very commonly used for the treatment of hyperlipidemia. And their efficacy in reducing LDL ranges between 5 to 35%. So they reduce LDL by 5 to 35%. This depends on the dose of the statin and the type of the statin used. There are powerful statins and there are weaker statins, and we'll talk about them shortly. In addition to lowering the bad lipid, the LDL, they raise HDL by around 5%. And they lower the triglycerides, which again is a bad lipid, by around 10 to 35%. They act by inhibiting the hepatic enzyme that is called HMJ-CoA reductase. And this is abbreviation for the hydroxymethylglutaryl-CoA reductase. This enzyme is responsible for synthesis of cholesterol in the liver. So by inhibiting this enzyme, the cholesterol concentration in the liver will decrease. This will result in a stimulation of the production of LDL receptors. So more receptors of LDL will be produced in order to counterattack the low level of cholesterol in the liver. As a result of the increased number of LDL receptors, there will be more LDL removed from the plasma by the hepatocyte. So there, at the end, the net result is reduction in the level of LDL, and this is simply the mechanism of action of statins. And the statins, they don't only reduce LDL, triglyceride, and increase HDL, but also there are some other possible benefits, such as secondary pleiotropic anti-atheromatous actions that were seen in animals. And also they slow neurodegeneration. So probably they are effective in cases of dementia or al-kharaf. Again, there are some studies that indicate that statins might be useful in some cases of a prostate cancer prevention, and there are many, many other possible benefits yet to be proven. If we talk shortly about the pharmacokinetics and pharmacodynamics of the statins, they depend on the molecular structure and depend on the intestinal absorption of statins. And usually, only 30 to 85% of statins will be absorbed by the intestine when we ingest them through the oral route in the form of tablet. And there will be hepatic first pass uptake, of course. Some of the statins require activation in the liver to be active. and some of them they are active by themselves and they don't require activation. And therefore, the systemic bioavailability, and we mean by systemic bioavailability the percentage of the drug that is bioavailable, that is active in the plasma and has the effect, the required effect, the pharmacological effect after ingestion by oral route. This systemic bioavailability varies between 5 to 30% of the administered dose. So, for example, if we ingest 10 milligram of a statin, we expect that around 5 to 30 milligram of that statin will be bioavailable in the plasma. And they divided in terms of their action into two groups. We have the short-acting statins such as simvastatin with a half-life of around 1 to 4 hours. That's why simvastatin is given at night. Why we give it at night? Because the maximum production of cholesterol by the HMG-CoA reductase inhibitor is in the early morning. So we give it at night, the simvastatin, in order to coincide its action with the maximum production of cholesterol. And we have the long-acting newer statins such as atorvastatin and rosuvastatin with a half-life around 20 hours. Therefore, these two statins can be given once daily at any time of the day, not at night. And unfortunately, statins exhibit what is called nonlinear pharmacodynamics. And what we mean by nonlinear, which means if we double the dose of the statin, we would not expect doubling the effect. We would expect that only 6% of extra reduction of LDL will happen when we double the dose. So this is called nonlinear pharmacodynamics. And this is a busy table. I would like you to concentrate on three major statins that are widely used in our locality and they are very common. The rosuvastatin, atorvastatin, and simvastatin. If we compare the dose of 10 milligram of each one of these statins in terms of reduction in LDL and triglyceride and increase in HDL, it's very clear we can find that rosuvastatin is the most powerful of all of them. Why? Because it reduces LDL by around 46% and triglyceride by 20% and increase HDL by 8%. So rosuvastatin is stronger than atorvastatin, and atorvastatin is more powerful than simvastatin. This is in terms of effectiveness and efficacy. What about the pharmacodynamics of statins? You can see here from this table that rosuvastatin is the only of the three hydrophilic. And you know hydrophilic means it likes blood. It loves water. So it is water soluble. While the other statins, the Atorva and Simva, are lipophilic. And the bioavailability of the rosuvastatin is 20%, which is higher than that of atorvastatin and simvastatin. And the protein binding is less, which means the active rosuvastatin is more than atorvastatin and simvastatin. And the active metabolite is minor compared with atorvastatin and simvastatin. And the majority of rosuvastatin is not metabolized by the cytochrome P450 enzyme. And the elimination half-life is 19 hours and the renal excretion is 13%. All of these together might explain why rosuvastatin is more powerful than the other. Statin is the most efficacious and effective statin in terms of LDL reduction. According to that, we can classify statins into three main groups. The first one is the high intensity statin, okay? And we have the moderate intensity statin and the low intensity statin. The high intensity statin is defined as a statin that reduces LDL by more than 50%. So if we have LDL of 200 milligram per deciliter and we want to reduce it to 100 milligram per deciliter, then we should use a high intensity statin. This includes rosuvastatin 20 milligram and atorvastatin 40 milligram. While the moderate intensity statin, they reduce LDL by around 30 to 50%, and this includes rosuvastatin 5 milligram and atorvastatin 10 milligram. And then we have the low intensity statin, which includes simvastatin of 10 milligram, and this will reduce LDL minimally by around less than 30%. So it depends on the level of LDL and how much you want to reduce LDL and your choice of the type of statin. Still, we are in the pharmacology, and for each drug, of course, there is adverse drug reactions. Statins generally are well tolerated, and there is a very minor side effect which happens in 1 per 10,000 patients taking statins, include myopathy and rhabdomyolysis, which is muscle breakdown, as you know. Another severe side effect, but is uncommon, is the elevation of plasma hepatic enzymes. But usually, mild elevation of plasma hepatic enzymes does not mean you have to stop statins. But you should stop statin, of course, whenever your patient develop myopathy, which is muscle weakness, and rhabdomyolysis, muscle breakdown. Majority of people on statin usually they have some sort of myalgia and they have some sort of muscle pain, which is minor and does not necessitate the stopping or the cessation of a statin therapy. And there is a drug interaction between statin and other agents, and this depends on the type of enzyme involved in the metabolism of a statin. So if the statin is dependent on the cytochrome P450 enzyme, all the CYP inhibitors, they will increase the risk of myopathy. Why is that? Because they will inhibit this enzyme, which is responsible for the metabolism of the statin, and we would expect a higher level of the statin and then consequently more risk of myopathy. Example of CYP inhibitors include grapefruit juice, and we call grapefruit, as you know, in Arabic, sindi. So grapefruit juice is is a potent inhibitors, and therefore it might increase the risk of myopathy. Again, verapamil is a calcium channel blocker used in the treatment of uh, some cardiac arrhythmias, might inhibit CYP and decrease the risk of myopathy. On the other hand, enzyme inducers, which mean they induce CYP, so we will expect a lower level of the statin in the plasma, and then a lower activity of the statin in the plasma and effectiveness. This include the antituberculous medication rifampicin and the St. John's wort. And the St. John's wort is a plant that is used for the treatment of depression. Another enzyme is called the OATP, organic anion transporter protein 2. So this OATP, if we take inhibitors of OATP2, we would expect reduce in the efficacy of statin. But interestingly, gemfibrozil, which is again one of the lipid-lowering agent from the group of fibrate, it inhibits both the OATP2 and the statin glycoronidation. This together will result in increased statin plasma level, and this will synergistically increase the risk of myopathy. The word synergistically means uh, both the drugs will potentiate one another. So gemfibrozil will potentiate statin, statin will potentiate gemfibrozil. Potentiate means make it more powerful. So we would expect more risk of myopathy if we use statin with gemfibrozil. Therefore, it is better to avoid the combination of fibrate and the statin together. And this is another table that shows the differences in the enzymes and the metabolism pathways for different statins. For example, atorvastatin and simvastatin, they have the same pathway. They are mainly uh, metabolized by the CYP, while rosuvastatin is mainly metabolized by the OATP2. So here you can see statins with a minimal CYP involvement, as I said. So rosuvastatin has minimal CYP involvement. Therefore, we would expect that grapefruit juice and verapamil, or the enzyme inhibitor, the CYP enzyme inhibitors, have little effect on rosuvastatin, while they have more effect on uh, atorvastatin and simvastatin, especially simvastatin. They can increase the level of simvastatin up to 4 to 12 folds. Okay. Now, what are the evidence that support the therapeutic use of statins? By other mean, what are the clinical trials? What are the studies that we got that proves the effectiveness of statin in reduction of mortality and cardiovascular event? So as you can see, this is a meta-analysis, and by meta-analysis we mean we collect many trials all together, we collect the data in order to get a single study with a large number of patients, and hence this study will be very robust, very strong, and it will give us the best evidence. So as you can see here in this meta-analysis, comparing the reduction in LDL cholesterol with the risk reduction in the major vascular event, as you can see, reduction of LDL by 1 millimole or 40 milligram per deciliter will reduce the cardiovascular event by around 22%, which is statistically significant. This p-value is very low, which means that this is a statistically significant result. So there are many, many trials and studies about the effectiveness of different types of statins in patients with diabetes and without diabetes. And the statins are the first line therapy for lowering LDL and reducing cardiovascular disease. These include the CARS, the AFCAP, and etc. And it was conducted on thousands of patients, as you can see here, with different statins, such as atorvastatin, simvastatin, etc. And here again, many, many trials on the effectiveness of statins in secondary prevention. And I will talk at the end of this presentation about the primary and secondary prevention. I will talk specifically on the most common one is the 4S study trial, which was about simvastatin effectiveness in reducing death, mortality, as well as LDL. It was conducted on more than 4,000 people. And this 4S is the Scandinavian simvastatin survival study. As you can see here very clearly in the yellow line is the people who were given a placebo, and the green line, the people who are given simvastatin, and they are followed up for 6 years. So at the end of 6 years, they found a 30% reduction in mortality in people who took simvastatin. So simvastatin increased survival by 30%. By other mean, it reduced mortality by 30%. And this is very good result. And in the same study, they found that simvastatin 20 milligram at the end of the 6 week of therapy reduced LDL by around 38% and reduced total cholesterol by 28% and reduced and increased HDL by 8%, which is again a very good result. Now, what is the meaning of primary prevention and secondary prevention? You as a doctor, you should, when you apply primary prevention, identify those at increased risk and offer them the uh, suitable medication or treatment in order to avoid the risk. If you look at this picture, you can see this man who is riding a boat and enjoying the weather and the ocean. Is very nice scene, and there is no problem. But you, as a good doctor, you shouldn't look at this scene as such. You have to identify the risk, which is seen here if you see the whole picture. So, as you can see, this is a shark going toward this man, and probably it will hurt him or eat him again, or might kill him. So, this is the primary prevention. The aim of the primary prevention is to identify people at risk and to protect them from that risk. The shark here represents the myocardial infarction and the atherosclerotic cardiovascular disease, and the man here represents the patient. But if this shark already attacked that man, here the primary prevention plays no role. But you have to apply the secondary prevention, which means you you will try to minimize the damage by saving the life of the patient from the shark. So, who should be, according to that concept, who should be on a statin? And according to the Cardiac, the American Heart Association, uh, there is ACC and AHA, the American College of Cardiologists and the American Heart Association. They identified four groups that might benefit from a statin. Those in red color represent the primary prevention, so they don't have the cardiovascular disease. And those in the black, they have the cardiovascular disease. So, in a simple, who people need or will benefit from statin therapy? Number one, those with established atherosclerotic cardiovascular disease, such as myocardial infarction, stroke, and peripheral arterial disease. Second, those without atherosclerotic cardiovascular disease but very high level of LDL defined as more than or equal 190 milligram per deciliter, they will benefit from statin therapy as a primary prevention. Third is people with diabetes with the age of 40 to 75 years. Again, they will benefit from statin therapy, any patient with diabetes and this age group. And finally, the same age group without diabetes but with an estimated 10-year risk of atherosclerotic cardiovascular disease of equal or more than 7.5%. And you may ask how we calculate this. There are special equations and applications that you calculate the 10-year atherosclerotic cardiovascular disease risk from certain variables such as the patient gender, age, smoking, etc., and family history. So these are the four major groups that will benefit from statin therapy as a primary and secondary prevention. And always, if you being asked by somebody, does the benefit of a statin outweighs potential risk? The answer is yes. The benefit of using a statin in these people in the form of reduction in LDL level and regression of coronary atheroma, regression of atherosclerotic cardiovascular disease always will outweigh the potential risk of some side effect such as a new onset diabetes, because the use of a statin might cause a new onset diabetes and the other side effects such as muscle symptoms or very rarely liver complications. So always benefits outweighs risk. Now we talked about the statin as the major drug for the treatment of hyperlipidemia, and we have other lipid-lowering drugs we will talk about shortly. We have the cholesterol absorption inhibitors, such as the ezetimibe. This ezetimibe acts by inhibiting the specific cholesterol transport protein. It blocks it in the brush border of the small intestine. Therefore, few lipid will be absorbed through the small intestine. This will result in reduction of LDL by 15 to 20%, but unfortunately, there is no effect on HDL or triglyceride. So usually we use ezetimibe either as a monotherapy in statin intolerant patients. So for example, your patient were given a statin and he developed rhabdomyolysis or severe myalgia, then you might give ezetimibe. But we can use it because it has synergistic effect if given in combination with a statin, and it will reduce LDL by a further 20%. The other group is the fibrate. An example of it is the gemfibrozil, and we have the fenofibrate. And they act on the peroxisome proliferator activated receptor alpha, the PPAR alpha. So they have a similar effect to statin, but usually they provide impressive lowering effect on triglycerides. So majorly they lower triglyceride more than LDL. Therefore, they are used as monotherapy for primary hypertriglyceridemia. And then we have the omega-3 fatty acid, which is called the fish oil. So as the name implies, they are derived from the fish, especially the salmon and the tuna. And these omega-3 fatty acid, usually they reduce the triglyceride, but usually they can minimal increase in LDL. And we have the biolysis sequestrants, example cholestyramine. So this is busy table. I will not get through it. I will leave it to you to read it through. You heard about the primary hyperlipoproteinemias. These are inherited disorders characterized by hyperlipidemia in the families and can cause heart disease. And we have 7 of them, and each one of them has its own specific features and own medication, preferred medication. And by this, we end the lecture. I hope you enjoyed it and made the benefit. And thank you.